Okay, today's webinar is organized under the theme A New Paradigm in the Dental Fabrications. As many of you know, conventional denture treatment often requires multiple patient visits and several clinical staff. Today, we will introduce a workflow that allows clinicians to capture comprehensive clinical data in a single visit while maintaining high clinical accuracy. This approach can help clinicians improve efficiency, improve chair time, and simplify the dental workflow. Before we begin the lecture, I'd like to briefly introduce the two key devices featured in today's webinar, JB Tray and JB Pork. JB Tray is an innovative tray system, as you already know, designed to obtain final impression and essential clinical records in a single appointment. It allows clinicians to obtain the information needed for dental fabrication in a more efficient way. Together with this, today, JB Fork is used to record important clinical information of maxillomandibular, such as the vertical dimension, central relations, midline, and lip support, such as things. When used together, JB3 and JB Fork help create a simplified workflow connecting clinical data capture and with digital dental design and fabrications. Now it's my great pleasure to introduce today's speaker. First, Professor Jungbo He from the Department of Prosthodontics and Busan National University School of Dentistry. Professor He is our key doctor, has intensive experience in prosthodontics and digital denture research, and today he will introduce the concept of JB3 and JB Fork, each clinical protocol, and the digital denture workflow. Second, we are also honored to have Mr. Yuran Zhang, the director of the JD Dental Laboratory, joining us. Mr. Zhang will share insight into the digital denture design process and laboratory workflow, as well as the integration between digital and conventional denture fabrications. We hope today's webinar will provide useful insight for clinicians and technicians who are interested in improving efficiency and accuracy in the denture treatment. With that, let us begin today's lecture. Please join me in welcome Professor Jungbo He.
Okay, hello. Wait a minute. Can you hear me? Can you hear me?
Yes.
Okay. Okay, can I start?
Yes.
Okay, wait a minute. Good afternoon, everybody. How are you? Nice to meet you. Thank you for having me. Anyway, thank you for attending this webinar. Yes, although you have different times. So now in Korea, 6 p.m. So, but I don't know your times. Anyway, I will start my first lectures. Yes, at first. So I'm Professor Jungbo He from Department of Prosthodontics, Busan National University, Korea. It's my great pleasure to share with you our latest innovation in denture workflow. In recent year, the demand for faster, more accurate, and patient-friendly denture fabrication has rapidly increased, right? So traditional methods often require multiple patient visits, especially complicated bottom molding and complicated jaw relation procedures. Anyway, to address these challenges, our team has developed two innovative systems, the JB Tray and JB Fork Radiplus solution, which together create a truly innovative denture workflow. So before starting my lecture, I would like to introduce myself. As I told you, my name is Jungbo He. I'm working in Busan National University. In university, I teach prosthodontics and treat complex patients at the university hospital. I have published 9 books so far, most of which focused on dental implant and implant assist to remove partial denture or overdenture. Nowadays, I'm interested in oral neck system. Anyway, I'm also continuously conducting research on integrating digital technologies into prosthodontic treatment. Today, I will introduce JB Tray procedure. That is the main topic, but including Pop-O system and JB fork system. So this developed is a little bit innovative materials in devices. I think so. So first, the device is Pop-O systems. This system is for transport occlusal plane information to dental technician. So you can use very simply these devices in your clinic. Second device is J-fork. This replaces the traditional occlusal wax limb. So last one is JB Tray. This is a moldable thermoplastic tray that allows you to take both the final impression and the jaw relation taking in a single visit. Before starting my lecture, I would like to introduce my colleague. So she is Professor So-hyun Lee, and he is Dae-sung Kim. They are my colleague and junior faculty members. They have also made a significant contribution to the development of new technique, and some of the images presented in this lecture will kindly provided by them. Thank you very much. This system receiving a lot of attention around the world now. I have been invited to a lecture about this system in about 12 countries so far. But running something new always takes time, right? So there is always a learning curve. That means you need some discipline, training, practice. So for dentists without strong basic training, for example, initial stage dentist, this system may feel more difficult at first. Anyway, I hope today's webinar will be helpful for you. So let's start. Okay, today I prepared 4 categories, 4 chapters. So in chapter 1, I will start with the conventional denture procedure explanation. So if you don't know conventional denture, you cannot use J-tray, J-fork, Pop-O systems. So before starting, I briefly explain about the conventional denture procedure. In chapter 2, we will review some basic concepts. How to decide vertical dimension, how to decide CR recording, how to decide occlusal plane. Okay, anyway, so we have to discuss about that. So after mastering this procedure and then you can move to the chapter 3. In the chapter 3, I will explain about just the border tray procedure. And in chapter 4, that is additional chapter. Yes, so nowadays we upgraded the JV fork, so including the lead opaque material. So I would like to introduce briefly about JV fork lead plus solution. Okay, let's start chapter 1. As I told you, we will talk about conventional denture procedure, and I will explain some terminology in my lecture. As many of you already know, the conventional denture fabrication process is built upon a well-established concept that has been refined over nearly a century. This process developed 100 years ago. What I want to say, this process really perfect. I believe like that, but there is some cumbersome situation, right? So it's really bit difficult because there are so many steps. So the patient have to visit almost over 5 times to make a final denture. So my concept is like this. This is JB Tray concept. So at the first visit of patient, I want to make custom tray. So using the JB tray, I can make custom tray at the first visit of patient, and then adjust the border molding, border mold, and then we can do a final impression using double step impression technique. I will explain later. This is second impression using right body of silicone material. We can do border molding perfectly and finish it upper jaw final impression. After making the lower jaw custom tray at the same day, in the oral cavity, I can extend the border, I can adjust the shape of a custom tray. And then I can do border molding simultaneously. Using the double step impression technique, I can do impression, take impression, first impression, and then I can do border molding one more time. I will explain detailedly every steps later. And then using the double step impression technique, I can do a final impression. Simultaneous border molding. At the same times, I decide the vertical dimension using JB tray. I can decide vertical dimension and central relation. So if you cannot decide vertical dimension or serial recording, you cannot use this JB tray, Lastly, I can attach pop-up systems between upper and lower lip. And then this pop-up system can transport occlusal information to the dental technician. That's all. At the first visit of patient, I can finish every steps. So, and then dental technician will make final denture. Today, I will explain about this simple procedure. But as I told you, you have to know the basic knowledge at first. So my concept is like this. In traditional denture protocol, the patient have visit over 5 times to make final denture. But I want to reduce first the 3 steps into only 1 step. And then we can change the publication method to digital publication. At that time, we can finish only 1 day or 2 visit denture fabrication. Before starting the detailed things, I would like to announce about the limitation of intraoral scanner, So recently there has been a lot of interest in digital dentistry. Because of this, many dentists believe that edentulous impression can be taken directly with the intraoral scanner. However, when we scan an edentulous ridge directly with an intraoral scanner, we are mainly capturing an anatomical impression, not functional impression. The result can vary depending on the operator. You can do it, but I cannot do it. So I believe everybody have to be done. So everybody have to do that. So that is very important. So according to the soft tissue retraction, the result can be different. So in my opinion, a more predictable approach is to first take a functional or a partial impression using a tray. And then the inner surface, can you see that? Anyway, inner surface of that impression can be scanned with an intraoral scanner or desktop scanner and converted into digital data. So I believe this approach is more predictable and clinically reliable. The reason why I say like this one, so when I travel another country for my lecture, so I met many dentists who are like to scan with intraoral scanner, direct scanning. So I worry about that. So you can do it, but another students cannot do it. So anyway, predictable procedure is most important. I believe like this. So this is not my opinion. So based on the many previous research, this tray used impression is better than intraoral scanner direct impression. So because of that, my lecture is based on the custom tray, functional impression, pressure impression, you know. You have to know about the closed mouth impression technique. So this term is very important to understand the JB tray. So my career, so I have over 20 years experience in dentistry, you know. So I have been teaching prosthodontics over 20 years until now. So, but I always teach to students about open mouth impression technique. Open mouth and then take impression. But when I use closed mouth impression technique, I could get high retention, high stability in lower jaw, lower mandible denture. So anyway, when we use the closed mouth impression, it can be recorded under functional condition while the patient is occluding. For patient who already have an existing denture, oh, thank you. This technique can be performed by allowing the patient to bite with the denture while the impression material hardening. Okay. The JB tray procedure was also developed based on this concept. So please remember the term of closed mouth impression technique. I will explain detail later. Okay, let's start the basic knowledge about the conventional denture. The border of the custom tray should be trimmed approximately 2 to 3 millimeter short of the deepest part of the vestibule. Why? Custom tray material is so hard. We cannot do bottom molding using hard material, right? So after making proper space of vestibule, and then we can use the moldable material to do bottom molding. So I want to ask you, what's the meaning of a custom tray? I believe that custom tray is only cover of edentulous area properly, not overextended. Proper extension and proper coverage is very important in terms of making custom tray. So after making custom tray, and then we could take a final impression. Taking an impression from maxillary edentulous arch is usually not very difficult, right? I believe you all can make a perfect impression in maxillary. However, it is important to carefully adjust the pressure area of the tray. Look at the white color arrow. So when I told you, I always use the double step impression technique. First step impression is for detecting the pressed area of the custom tray. When I use the JB tray, okay? In addition, the vibrating line in the posterior area must be clearly recorded. Red line indicated the posterior border of a posterior dam. The red dot indicated the palatine foveas. And yellow line showed the anterior border of posterior dam. This part is very important, right? At first, we have to mark these two palatine fovea, and then we ask the patient to make a sound, and then we can mark the vibrating line. So generally, the posterior border of denture, upper denture, will be located between palatine fovea and then vibrating line. So we have to detect the exact anatomical structure of palatine fovea and vibrating line. Anyway, I want to skip the upper jaw final impression because I believe you all know about that. So today, because of time limitation, I will go to the mandible directly, okay? So from now, I will divide 4 areas, 4 part of the mandibular denture. So the first important area is retromolar pad area. Okay, when making a lower denture, the retromolar pad is very important for good stability, not support, stability and retention, you know. It must be fully covered and fit well, not when the mouth is wide open. That is important. Not when the mouth is wide open, but when the patient is at rest or gently chewing situation. At that time, little pad area have to fit well. This is because most actions like chewing and talking happen when the mouth is open slightly open, or when the mouth is moderate open, not wide open. So that is key point. This red colored area is retromolar pad area. The blue color indicated the buccal shelf area for support. Red color retromolar pad area is for stability or retention. Blue color indicate the support. So anyway, according to the area of the denture, the lower is a little bit different. Totally different, right? So anyway, as shown here, the retinal pad stretches when the mouth is wide open. Can you detect the difference between opening and closing? So when the patient opened the mouth widely at that time, this retinal pad is stretched like this. But when the mouth is at rest or lightly closed like this, so it returns to be relaxed and curved shape. If the impression is taken with the mouth too open, widely open, the denture may not fit well in this area when the mouth closed. This can create a gap here, so causing air leakage and pool retention. So to understand, because of pterygomandibular lappe, and then because of the surrounding muscle like superior pharyngeal constrictor muscle or bacinator muscle, when the patient opened the mouth, generally this lappe area will be stretched. So when we take impression, so we have to make relax the position of retinal pad. That is very important. So another important point of retinal pad area is the width of this part, width. If this area is made too wide, it may prevent the formation of what we call the British point. So this is from the, Japan. Yeah, Japanese concept. Anyway, after focusing to this British point, I could increase the retention of the denture. So I believe this British point is very important. So the area where the buccal mucosa here and the tongue side were meet together, that is the British point. When the British point is properly formed, the retinal pad becomes well enclosed by the surrounding soft tissue, significantly enhancing the retention of denture. However, if the area is too wide like this, and this contact is lost, air leakage can occur, compromising the denture's retention. If this area is not properly contoured into a concave shape, this part, Any movement, such as speaking or opening the mouth, may cause the denture to lift, reducing its stability. We can say this part, masseteric fold area, masseteric fold area. In Japanese, there's called somea wrinkle. So I don't know exactly. Anyway, masseter fold. This area across the masseter muscle and pacinator muscle, right? So because of the when the patient move or activate their muscle, sometimes this area could make the notch and fold. So if the little pad area extended or covered this part, when the patient move or speech or swallowing or talking, at that time, this supporting area could lift the denture. So you had to better check this part, concave part. And second important thing is the thickness of lingual denture fringe. So anyway, you have to remember the BTC point importance, okay? So look at this case. This patient visited my clinic complaining the lack of retention of posterior part. So after wearing this denture and I checked the posterior part, so at that time I can see the air leakage. There was no BTC point. Buccal cheek, tongue have to contact together. But when the patient make the last position, I could see the leakage, air leakage. So I checked the problems with the pitch checker. At that time, I could detect the thicker lingual fringe. And then I could detect some pressured area in the masseteric notch area. So, and then I changed it, the thickness of lingual part like this. I reduced the thickness, and then I made perfect, yes, concave curvature, based on the, yes, masseteric notch. At that time, I could see the BTC point, BTC contact point, BTC point. The retention have changed, you know. So when the patient bite something using the anterior teeth, the posterior retention could be detected. So I believe this kind of BTC point and proper extension of retinal pad area, the well pit of retinal pad area is very important. The next area we need to consider is the posterior border of the retromolar pad area. If the denture extends too far posterior like this, the pharyngomandibular lappe may easily lift the denture during function. You know? In addition, if the extension is excessive, the distance to the hemilunar notch becomes too short. Do you know that the occlusal plane generally located to the below, how can I say, 0.8 to 0.8 to 1.0 centimeter. Yes, distance. So if you make the proper space in hemilunar notch area, so you can arrange the artificial teeth properly in upper jaw, you know. But if you overextend this part, you cannot make the proper space. So therefore, this area should be carefully evaluated. This is especially important when performing a closed mouth impression. As I told you, today's lecture is based on the closed mouth impression technique. But if this part is overextended, the patient cannot close their mouth when we take final impression. To understand, we have to check this part not to overextend. Do you remember everything about the retinal pad? The second important part is lingual fringe. This part, lingual fringe part. This area. So we have to focus the mylohyoid muscle. What is the mylohyoid muscle? mylohyoid muscle attached from the mylohyoid ridge to hyoid bone. As you know, the hyoid bone continuously move, right? When the patient is swallowing, speaking, tongue lifting, in every activation, the hyoid bone move up and down, right? So we have to focus the movement of mylohyoid muscle. The denture base should provide sufficient space to permit muscle movement, mylohyoid muscle movement. Accordingly, the flange must follow the upward contour of mylohyoid muscle and be extended 2 to 3 millimeters beyond the mylohyoid ridge to improve denture stability. So can you see the pink color over here? Those kind of extension is better. If the denture base impinge the muscle area, definitely the patient feel discomfort or pain. Okay, look at this picture. What's the problem of this picture? So this is mylohyoid ridge area. So the lingual flange have to cover the mylohyoid ridge, about 2 to 3 millimeters, right? But there is no space for movement of mylohyoid muscle. The lingual flange have positioned like this. Oh shit, sorry. Like this, you know? So you have to make the proper space for mylohyoid muscle movement. Do you understand? So this is very important factors. So when we showed the anatomical structure, so you can see the direction of the muscle like this. So this is hyoid bone, mylohyoid ridge. So anyway, you have to remember the proper space for movement of mylohyoid muscle. Okay, to make a proper shape, to make a proper thickness and length of lingual flange, these two motion, yes, activation is very useful. The forward movement of the tongue, which extends enough to lick the lip, determines the length of the denture border. The upward movement of tongue, which strongly presses against the anterior palate and causes the base of the tongue spread widely. So you can determine the thickness of the denture border. Okay, you had better remember these two motions, but don't open widely like this. To take a photos, the patient is opening mouth widely now, but when you move the tongue, so the rested position, slight opening is better. Slight opening, okay? Okay, third area is sublingual fold area. Sublingual fold area. This area moves a lot and usually doesn't hurt with light pressure like this. So I push this part using the meter handle, but the patient didn't complain about the pain. So because of its mobility, a slightly thick and overextended denture flange here can improve retention. Okay, look at this figure. When the patient's mouth is closed like this, left figure, the tongue generally envelops the lingual flange of the denture. However, when the mouth is open like this, in some patients, not 100% of patients, in some patients, the tongue and the sublingual fold may move posteriorly together, which can disrupt the seal, suction. Since slight extension, so what do you think about this? Since slight extension with a gentle compression in the sublingual fold area usually does not cause a significant discomfort, as I told you. So I think that extending this region slightly wider may help maintain the seal even when the mouth is opening. When you make the denture, you had better make slightly overextended sublingual fold area could improve the retention when the patient opened the mouth. Do you understand that? Do you understand about this? Okay. So this is my impression. So after taking a final impression, we can see the proper thickness of sublingual fold area. And then in the lingual pharynx area, we can see the very thin lingual pharynx. Okay. So I always emphasize about 2 millimeter thickness, about 2 millimeter thickness of sublingual fold area, and the very thin, about 1 millimeter thickness of the lingual pharynx or posterior part area. So those kind of picture could be made, yes, in your clinic. So if you understand about this concept, okay? This patient came to our clinic complaining that his denture was not fitting well and often dislodged. So I decided to perform a chairside directed lining procedure. During examination, we noticed that the patient had a broad sublingual fold area. And when opening the mouth, the tongue tended to retract posteriorly. In such cases, it's crucial to form the sublingual area thicker with intention, okay? Otherwise, the denture border will not be enclosed by sublingual soft tissue during tongue movement, and the retention will be lost. Also, I checked the retinal pad area. The retinal pad area changed its shape dramatically when the patient closed the mouth, opened the mouth, closed the mouth. You can see the curvature of the retinal pad area. So the final impression must be made in the closed mouth position to capture the functional form of this lesion. So this is final result after direct chairside relining. We can achieve a stable and retentively lined denture that adapt well to the dynamic movement of the oral tissues. This case clearly demonstrates how the closed mouth impression concept is essential, not only for new denture fabrication, but also for relining procedure as well. So you can detect the change of the sublingual fold area, and you can see the curvature of the retinal pad area, okay? The first important area is polished surface in buccal aspect and lingual aspect. The polished surface of the denture base should be shaped with a concave contour. You have to remember the concave contour, allowing the lips and tongue to rest comfortably in their natural positions. This is lip, right? This is tongue. The translucent red color shows the tongue. So tongue have to positioned, yes, properly, yes, on the lingual pharynx, lingual polished surface, okay? That because to make those kind of, yes, rest of tongue, you have to make a concave shape of lingual polished surface. Okay, let's move to the chapter 2. So now I'm talking about various topics. So I'm so sorry, but if you don't know about the basic knowledge about the denture, I cannot explain about the JB Tray procedure. So I hope you're understanding about that. So second chapter, I would like to explain vertical dimension, CR recording, occlusive plane deciding very briefly. Yeah, so because of time limitation. So generally, in the conventional complete denture, we have to use occlusal wax rim for jaw relation recording, right? So after making the occlusal wax rim, we have to decide occlusal plane at first. Occlusal plane. Second, vertical dimension. Third, center relation. And then we can do pacebo transpo. But to be honest, in my clinic, I don't use a pacebo transpo when I make the denture. So I don't know the difference when I use the pacebo transfer or PAPO system. So I will explain about that. Anyway, you have to remember these orders to take a jaw relation recording. After deciding the CR recording, after taking the center relation recording, you have to mark some reference line to transfer patient information to the dental technician. The first line is midline. That is very important, right? So midline. The second line is ala line, indicating the position of the upper canine cusp. So if you mark this line, you can indicate the proper size of anterior 6 teeth, right? So the third line is angulus oris line. Although I mark this line on the lower occlusal wax rim, but this aligns with the distal surface of the maxillary canine. So in case of woman, girl, so they have a little bit different position of angulus oris. So at that time, we have to mark two kind of things. Number two, ala nose, and then angulus oris. At that time, we can decide the proper size of anterior teeth. So, one more time, the angulus oris indicate the distal surface of maxillary canine. Okay. This is high smile line. Very important reference for determining the length of anterior teeth, exposure of anterior teeth. This is related to the aesthetic, right? So high smile line, and then make the smile line, and then we can mark the lower border of upper lip. And then last one is the incisal line. So until now, did you mark these lines in your clinic? If you do that, you are excellent denturist or dentist. But if you don't know about this concept, so you have to be careful. Yes, from now. So you have to mark everything. So anyway, in JB Fork and JB Tray, I always try to include this information in that devices without occlusive wax limb. So the reason why I explain these lines, so I would like to introduce JB Tray and JB Fork function, yes, later, okay? So to be honest, I don't like the occlusive wax limb because why? Because so when using occlusive wax limb to record the intermaxillary relationship, premature contact causes the limb base to shift. For example, if the anterior region makes contact first, the posterior limb may lift. Do you understand? So this might falsely appear as an even contact. So the dentist and patient couldn't detect the slight deformation or slight lift of posterior part. This can result in an inaccurate interocclusion, bite checking. So after making the denture, you can see the disclusion in posterior teeth. Oh my God, what's the problem? So that is because of the error of occlusal wax rim. So you can see the severe movement, severely moving the denture. So at that time. So because of that, I don't like use the occlusal wax limb in my clinic. So, okay, so from now, I will explain about the occlusion. Yes, occlusion. So occlusal plane, vertical dimensions, yeah, recording briefly. So now let's take a closer look at the occlusal plane. When viewed from the front, the interpopular line. This interpopular line is typically aligned with occlusal plane, right? That is the natural things, right? For the anterior reference of the occlusion is the maxillary anterior teeth. Maxillary anterior teeth should be visible about 2 millimeter below the upper lip when the patient is at rest. 2 to 3 millimeter. In case of elder patient, 1 to 2 millimeter. So according to age, this appearance of the anterior teeth is changed, okay? Additionally, the mandibular incisors should follow the contour of the superior border of the lower lip during the resting position. What's the resting position? The M sound position. Emma, Emma, Emma. When your patient say like this, Emma, at that time you can make the rest position. Okay. When viewed from the lateral aspect, the occlusal plane is generally parallel to campus line. This is campus line. So ala, tragus, connecting line. This is campus line. However, this is simply a clinical reference, not a strict rule. As for posterior reference points, the occlusal plane should be positioned approximately 8 to 10 millimeter below the hemular notch. This is hemular notch. We need about 8 to 10 millimeter space to position second molar, right? So in case of Asian people, so because of that, the Asian people has the, lower inclination of the campus line. So he's Asian guys. So because of that, this occlusal plane is a little bit, yes, lower than campus line, right? So to obtain proper space of posterior part. Okay. Anyway, you have to remember this campus line. This is tragus. The center of tragus connected to this ala point. In Asian people, the lower border of tragus connected to the ala. So this line is same with the occlusal plane. So generally, that is my criteria. So you can change this criteria compensating with the patient condition, okay? Generally, tongue border have to follow the occlusal plane. So when you check the occlusal plane, you had to better check the tongue border. Yes. So anyway, you have to match together tongue border and the occlusal plane. Okay, let's move. So this is Papo systems. So in my clinics, I always use the Papo systems to indicate the middle line, interpopular line, lateral side, the campus line parallelism, and then we can check the left and right side balance, symmetry, So using the silicone bite material, we can attach this Papo system in every case. When you take a final impression, when you take a preliminary impression, you can attach this Papo system on the handle of the tray. When you take a bite registration, you can put this Papo system into the silicone material. So you can take the jaw relationship. Sorry, you can transfer the occlusal plane information to the dental technician in every step. Okay. Why not move? Okay. So this case showed the Papo uses how to use the Papo systems. So when you take a final impression, you can attach these purple systems like this, and then adjust the campus line and interpopular line parallel with interpopular line, and then you could check the left and right side balance, and then you can mark the between the joint area